When we look at the prostate, we always look at the seminal vesicles. Seminal vesicles are just above the prostate. They angle posteriorly from the prostate, and they have to be symmetric. I mean, here's a size, an average size for a seminal vesicle, but we don't look that much at the average size, but we look at the symmetry. This here is the vas deferens coming in medially, here and here, and this part here is SV on each side. The seminal vesicles themselves taper as you get towards the apex of the prostate. So here we see seminal vesicle tapering here. This is the arrow pointing to the vas deferens, arrow pointing to this is the ampullary portion of the vas deferens, and a seminal vesicle coming here. Now the vas deferens is most clearly seen here because this is the most distended part of the vas. It's called the ampullary portion. But if you turn on this, you can actually follow this vas deferens out, and sometimes you can follow it out laterally to where the ureter crosses under the vas deferens. Ductal ectasia is a process where there is dilatation of the ducts within the seminal vesicle. Here's a patient with bilateral ductal ectasia. Ductal ectasia is often associated with BPH. So the benign prostatic hyperplasia results in enlargement to the prostate and a relative blockage to the egress of the seminal fluid from the seminal vesicle, and therefore ductal ectasia bilaterally. When ductal ectasia is unilateral, one should be looking for a reason to see if there's a mass or some kind of calculus obstructing the seminal vesicle on that side. Ductal ectasia is probably the most common abnormality that one will see of the seminal vesicle. This is probably the least common abnormality one would see, which is seminal vesicle cyst. An isolated cyst in the seminal vesicle, extremely rare. Most of the time when you think you have a seminal vesicle cyst, if you look harder, you'll probably see that it hooks up with the ductal structures, and it's really ductal ectasia. But isolated seminal vesicle cysts are associated with congenital anomalies of the seminal vesicle and of the kidney. The seminal vesicle happens to be a Mullerian structure, and so this will be associated with other types of Mullerian abnormalities. Talking about Mullerian structures, the Mullerian duct comes down into the middle of the prostate, at the base of the prostate, and cysts that are midline cysts that are actually in the prostate or exophytic above the prostate, maybe remnants of this embryologic Mullerian duct, and they're called Mullerian duct cysts. The significance really is to recognize that this is a benign process, and unless the Mullerian duct cyst is causing symptoms, if it's infected or if it's obstructing the ejaculatory ducts, there's no reason to treat it, just let it be. The other cyst that can be seen in the prostate is the ejaculatory duct cyst, and in general, the ejaculatory duct cyst here is the just off midline. You can see the dilated seminal vesicle. There's actually ductal ectasia of the seminal vesicle. There's a little calculus here in the ejaculatory duct, and there's an ejaculatory duct cyst here. Ejaculatory duct cysts are often associated with dilatation of the ejaculatory ducts, and they may be associated with infertility. So it's a chicken and egg question here as to whether the ejaculatory duct cyst is the cause of the obstruction or the obstruction somehow results in an ejaculatory duct cyst. Before we go any further talking about the ejaculatory ducts and the relationships of the different parts of the prostate, it's important to understand the zonal anatomy. And the zonal anatomy here is basically a way of breaking up the prostate into 4 different zones and categorizing where the lesions are. So the inner gland, which we talked about before when we talked about benign prostatic hyperplasia, consists of the tissue which is right around the urethra, which is the periurethral tissue, and a very small amount of tissue which is present only above the level of the viru, which is the transition zone. So in a normal teenager, probably no more than 5% of the volume of the prostate consists of this periurethral tissue and its transition zone material. The outer gland is a much, much more significant part, more substantial part of the prostatic volume, and that consists of the central zone, which is present from the base of the prostate up to the viru, and the peripheral zone. Now, each one of these zones has glands that open into the urethra, so there are prostatic secretions that end up in the urethra from each one of these zones. So the 4 glandular zones are the periurethral zone, the transition zone, the central zone, and the peripheral zone. These 2, the periurethral and transition zones, are part of the inner gland. The central and peripheral zones are part of the outer gland. On ultrasound, we cannot distinguish central zone from peripheral zone. They are both in the outer gland. It's very important to understand that nomenclature. So if someone says to you central zone, that does not mean that they're talking about the inner part of the prostate. That may very well be at the base of the prostate in the outer part of the prostate. Okay, but pathologically, that's defined as a central zone tissue. And it all empties through ducts just above the level of the vero. Finally, there's fibromuscular stroma, which is present anteriorly in the prostate. That is not glandular tissue. On ultrasound, we can differentiate the inner gland from the outer gland. The distinction usually is that of a different echogenicity, the inner gland being more hypoechoic, the outer gland being more echogenic. Here again, inner gland being more hypoechoic, outer gland being more echogenic. The process of benign prostatic hyperplasia is almost exclusively in the inner gland, usually involves mostly transition zone. Remember, the inner gland was supposed to be 5% of the prostate volume, but look at this. This is much more than 5%. In fact, this is more than 50% of the prostate volume, and this is a process of benign prostatic hyperplasia, enlargement of the inner gland, which is associated with aging in the normal adult in our country. So this is outer gland here, which could be central zone and peripheral zone, and this is inner gland, which is mostly transition zone hyperplasia. So if there's one thing I need you to take home from this lecture, is that there's glandular anatomy of the prostate, dividing it into the inside, periurethral tissue and transition zone, the outer gland, central zone and peripheral zone. This is commonly affected by BPH. A small minority of cancers are seen in the inner gland. Our diagnosis of cancer predominantly involves the outer gland, central zone and peripheral zone, and prostatitis also predominantly involves the outer gland of the prostate. So let's talk about some of these entities now. Clinical BPH is a clinical entity. You see poor bladder emptying, urinary retention, so increased post-void residual. You can see detrusor instability, so the person is not able to hold and release urine properly. It can lead to urinary tract infections because there's stasis of urine, it never empties out of the bladder. BPH can be responsible for hematuria and can also be responsible ultimately for obstruction leading to renal insufficiency. The diagnosis is made by the digital rectal exam and ultrasound and by the clinical symptoms. Now, we can often find enlargement of the prostate by ultrasound, which will give us the ultrasonic diagnosis of BPH, but that may or may not be associated with clinical symptoms. So here is an example of ultrasonic BPH. Here's the prostate. Here's the inner gland, which is so large that's extending all the way up into the bladder. And this is a type of BPH which is commonly called median lobe hypertrophy. The older anatomic descriptions of the prostate had a lobar anatomy. The median lobe was that part that was in the middle that bulged up into the bladder neck. We still retain that nomenclature for this type of BPH, but we do not believe that there really is a true median lobe as opposed to a lateral lobe. That's an old nomenclature which is no longer used in the prostate literature. Now, prostatitis can be acute or chronic. Only about 5% of prostatitis is bacterial. Most of prostatitis is either non-bacterial, which means you can isolate something like chlamydia from it, or prostatodynia, which is prostatic pain or symptoms not related to any identifiable source of infection. So here's a patient with prostatitis. You can see a heterogeneous outer gland. You can see increased flow in some areas, which may be markers for prostatitis. If prostatitis progresses, one can actually have abscesses form within the prostate, and here we see multiple anechoic areas in this prostate. Some of them are surrounded by markedly increased blood flow, as seen in the Doppler, and so that's classic for prostatitis. Okay, so we talked just for a couple minutes on prostatitis. Perhaps the more important or more common reason for doing prostate ultrasound is prostate cancer. And here it's usually being done because there was an abnormal rectal examination or because there was some type of abnormality on a PSA blood test. What does prostate cancer look like? Well, classically, prostate cancer on grayscale is hypoechoic. There you see the hypoechoic lesion. It bulges the contour of the prostate. So there's a contour abnormality and an echotexture abnormality. I would tell you that less than 50% of prostate cancers are obvious like this, but this is the classic description. And often the color Doppler will show increased flow within the prostate cancer, which is what you're seeing here. The normal peripheral zone has very little Doppler flow, but with cancer, as the grade of the cancer goes up, especially, we see more and more Doppler flow.